Minimal residual disease is really a hot topic these days in hematology. In every single disease you address, definitely there is a role of MRD, both for prognostic as a prognostic marker, but also for guiding therapy. And this is now very well established in acute lymphoblastic leukemia, Hodgkin lymphoma, non-Hodgkin lymphoma, CLL. What we have seen in this meeting at EHA in Stockholm 2018, we have now data in AML, acute myeloid leukemia. And this is really very interesting because until recently, the data in acute myeloid leukemia were rather poor because, of course, it's a heterogeneous disease. The techniques to quantify MRD in AML are not as easy as in other diseases, but now we do have accumulating evidence showing not only in AML in first complete remission the value of MRD, but also it has been presented in this meeting on behalf of the Acute Leukemia Working Party of EBMT in more than 1,000 patients, the value of minimal residual disease status before transplant in those patients who are in second CR after relapse. And clearly, if your patient are in negative MRD prior to allotransplant, even if they are in CR2, this will impact the outcome after transplant. And those patients who are transplanted in negative MRD are going to enjoy longer leukemia-free survival because of a lower incidence of disease relapse. So I think this is these are very solid and important data that will allow us in the near future to refine our approaches, because now we have many new targeted drugs, let's say, available that would allow you, before proceeding to transplant, to treat the disease and try to achieve MRD negativity. But also we can use this information in the MRD positive patient who proceed to transplant to start very early after transplant some of these targeted drugs to keep control of the disease. So it's really very exciting. MRD is here to stay all over the place, and this will allow to improve patient outcome.